Welcome to the pre-intubation checklist training session for this quality improvement project. The objective of this QI project is to implement a standardized pre-intubation checklist at Alton Memorial Hospital to reduce hypoxemia, number of attempts, and hemodynamic instability during and post-intubation. Each step in this checklist is designed to maximize patient safety, improve first-pass success, and minimize complications. This is what the checklist looks like. It has a pre- and post-intubation section. The checklist will be located in the airway boxes with the respiratory therapists. Let's briefly walk through each section and discuss why each step is important. Under patient assessment, proper positioning optimizes the view of the vocal cords, making intubation reducing the risk of complications. Identifying the need for spinal precautions prevents further injury in trauma patients. Early recognition of difficult airways allows for preparation of advanced airway equipment and backup plans. Checking for allergies avoids life-threatening reactions to medications used during the intubation. Reoxygenation increases oxygen reserves, prolonging the safe apnea period and reducing the risk of hypoxemia. We can pre-oxygenate with either bag mask valve or a non-rebreather mask at least 15 liters per minute at 100% FiO2 for at least 3 minutes. It is important to ensure ECG, SpO2, blood pressure, and capnography monitors are attached. Continuous monitoring allows for early detection of hypoxemia, arrhythmias, or hypotension. Adequate IV or IO access ensures rapid administration of drugs and fluids if needed. It's important to make sure that a functional laryngoscope is available, in addition to a bougie or a stylet, the correct size of the endotracheal tube with backups ready if needed, as well as alternative airway devices such as an oropharyngeal airway or an iGel. Immediate suction availability prevents airway obstruction from secretions or vomit. Prior to the intubation, induction and paralysis drugs should be drawn up and labeled. Post-intubation sedation drugs should also be ready to ensure patient maintains comfort and safety post-intubation. Ready access to vasopressors allows for rapid treatment of peri-intubation hypotension. Once all items on the pre-intubation checklist have been accounted for and the intubation is about to be performed, a timeout should be called. Patient identity should be confirmed along with the reason for intubation. Roles should be clearly allocated and a contingency plan discussed. All items on the pre-intubation checklist should be verbalized by the one who calls the timeout. Once the intubation has been performed, a post-intubation checklist should be completed. The tube placement should be confirmed with capnography, which is the gold standard for confirming tracheal placement. Tube depth should be checked to ensure that the tube is not too shallow or too deep. Bilateral chest rise confirms both lungs are being ventilated. The endotracheal tube should be secured with either tape or a holder. Ongoing care measures should be arranged for. Appropriate vent settings should be set. Hemodynamic stability should be monitored. Sedation and analgesia should be started. Every step in the intubation checklist is vital for patient safety and procedural success. Following this systematic approach helps prevent errors, anticipate complications, and ensure the best possible outcomes for patients. Thank you.